Hello and welcome to our extra special video for you today, which is going to be on history taking. We've decided to make this video as a direct response to some of the students and their up and coming OSCE examinations on history taking and not really knowing what it is that they need to do. Well, basically what I'm going to do is I'm going to take you through a couple of easy steps on history taking over a couple of videos. And I'll be using the Calgary-Cambridge framework for history taking. I'll be modifying it a little bit so that I put in some extra little gems to help you in your future clinical practice. And without further ado, we shall move to the board and begin. So, history taking involves Calgary-Cambridge framework, 10 easy steps, and we start off with number 1, which is PP, okay? And in the PP, that stands for your patient profile. Patient profile normally takes into factor the 3 identifying factors, which are an absolute must. Okay, so that's the name, age, date of birth. What you can normally do here for some added extras is get the gender patient you're dealing with, and if you want some extras here, get in your occupation of the patient you're dealing with, and normally that gives you a rough idea of what you're dealing with, okay, or who you're dealing with. So the next thing we go to now is PC. Now PC, okay, stands for presenting complaint. This is the reason why the person came to see you at the doctor's today. Right. Now remember, PC has normally got something behind it, yeah? All the stuff behind the scenes that you didn't see is located in the PC. That's because when people come to the doctors, there's a lot that's happened behind the scenes before they actually walk into your consult room at the doctors. They might have thought about it for days and thought, well, you know, if that's a pain, I'll think, I'll see how it goes. And maybe in 2 weeks' time, if it's still there then I'll go to the doctors. Or they've gone around and seen other people and said, I've got a pain here, what do you think? Do you think it's something serious? Do you think I should go to the doctors? And then normally they go and see somebody they really respect. It's normally people's grandmothers who've seen it all. And they go there and they see them and they say, oh, yeah, I've got this problem. So, oh, get yourself down to the doctors. You'll be crazy walking around with a thing like that. I wouldn't even mess around. I know somebody who had something like that once. Oh, it didn't end up in a good way. And then they soon get down to the surgery to see. Okay? So that's your presenting complaint. Remember, this is what the patient tells you is wrong when they come. And to elicit this, what you normally have to start off saying is something like, and so, what is it that I can do for you today? Right? Don't fall into the trap of saying things like, so what brings you here? Because that's when people come up with really, really smart comments like, I came by bus, doctor, or I was brought in the ambulance, doctor. Okay? So that's your presenting complaint. So you've got things like cough, pain, can't sleep, weight loss, palpitations, okay, so these are all your presenting complaints things. Next, number 3, history of presenting complaints. HPC, history of presenting complaints. Now I'm going to write here this is equal to the gossip, okay? This is the place where those of you who like to gossip and get the juice on people, you can get people down, straight down, okay? This is the sort of place where those people who like to gossip, they can just have the patient exposed within a couple of minutes. Everything about them, okay? Imagine going into a room where you've got somebody who's really good at being gossipy and they can just ask you 1 or 2 questions and they can just leave you exposed. And you've revealed your innermost, darkest secrets. Okay. This is where they do well. Why? It's because they start off with a very open question. Hey, so how are you doing today? Oh, right, okay. Yeah. And where is it you live again? Oh, right, okay. And they get deeper and deeper and deeper and deeper, and before you know it, you're exposed for who you are. So always start here. Students always trip up here. Always start with an open question, especially for exams. Always start with an open question. So typical open questions are, so what is it that we may do for you today? Okay, and the patient normally then has their cue to begin talking, and they'll say, well, what it is, doctor, for the last couple of weeks I've just not been right. I've just had this pain, and it's come and it's gone. It's just beginning to affect me at work now, and I just went to the pharmacy. I took some pills and things, and it's not getting any better. Some standard stuff at home, and I just thought I'd better come and see you because I'm really worried about this now. Okay, and they just give you everything right there. Now, there are some people who can really just talk the hind legs off a donkey. Okay, now for those people, you have to make sure that you curtail how much they say after a little while. But normal research says that if you allow people to start talking, they can talk up to about 2 minutes normally, and then they stop. Maximum 2 minutes-ish, and then they stop. But remember, in obviously you only have 5 minutes or so. So to allow someone to talk for 2 minutes, you might leave yourself a bit short-changed. So just be a bit careful with that. So a typical one which works quite well is if the patients come in with something like a pain history, you can use something called Socrates. You can still use Socrates for all other histories of presenting complaint, but it works very well for pain. I'm going to take you through the pain model, and then with that you can transfer it and use it for other presenting complaints in future. So let's take you through Socrates, because it's quite comprehensive in the things that it covers. So S in Socrates stands for site. So this would be the site of the pain. Where is it? And normally patients can point to a pain. Like, oh, I think it's there, I think it's there, I think it's here. O, onset. Okay, so it's onset of the pain. So how fast did it come on? Did it come on quite suddenly, or you sat there just playing around 1 minute and suddenly, or did it come on quite slowly? And it was like in the afternoon at lunchtime, just felt that little twinge or a niggle, and then by the evening you were just beginning to struggle. And then by the night time you couldn't even get to bed because the pain was just intolerable. So onset. C is the character. So the character of the pain. Now you always get people asking you, so was it a sharp stabbing pain? Now stabbing, there's not many people who've been stabbed, you know, so there are not many people who've had the pleasure of being stabbed, unfortunately. So to be able to say to you, yes doctor, it felt just like that time when I was stabbed, I think it's been a little bit unreasonable to ask the patients this. So the sort of things that you can ask is, can you perhaps describe the pain to me? What does it feel like? And people are very good at describing things, so you'll be surprised. Give them a chance, and normally they'll come up with, well, doctor, it just feels like as if there's somebody inside my tummy just wringing things out, like trying to wring out things, and just squeezing and squeezing. And then, oh, it feels like something heavy, doctor. Something heavy is pushing just right down here. Oh, it just feels intolerable. Okay? So they can tell you about the character. Well, it feels quite sharp. It just feels like a thorn in my side. How they got a thorn in their side, I don't know. But people sometimes do say these things. So let them use their words rather than telling them about stabbings and so and so. Then we go on to radiation. Radiation. From the R. Radiation is when you get the pain there, where you said it was, site, does it go anywhere else? Okay, does it climb up your arm and down your left arm from your heart, say? I wonder what that could be. Or is it one of these pains which just stays in one place? So radiation, and that could tell us as doctors, because we know about the nervous system, where nerves go, gives us quite a lot of information, we think, if it radiates somewhere. A is associated factors. So, when you get this pain, what else is it associated with? Some people say it makes them feel sick, they just want to vomit everywhere. Okay? Some people say, oh, you just get up and come out in the sweat, all over in the sweat. So these are things that you want to elicit, or is it something they were doing? Yeah, something they were doing when this pain came on. So it's only when I'm in the garden and I'm thinking like this, just like this, it just comes, right? Twinge. T is for timing. Okay? So some pains have a timing. They only come in the morning. So an example, every morning I get up, doctor, the same problem. Yeah. Or in the evening, it's final day, and at night, just when I'm ready to go to bed, there it all kicks off again. Okay. Remember, there are also pains which are cyclical. Okay, and a typical one would be something associated with cyclical changes. So reproductive, you can say in women with periods, around the time of a period, they may get a cyclical pain, so every 28 days or so. You may also have, in the kids, those pains which only come when it's time to go to school. So don't forget, we are only human after all. E is exacerbating and alleviating factors. Oops. There we go. Recovery. So exacerbating and alleviating factors. So this is exacerbating. What makes it worse? What makes it only make the pain worse? Oh yes, doctor, absolutely. Every time I go to just do that, say, oh, just feel it coming right around here. Agony, absolute agony. Alleviating factors is like, oh doctor, you know, when it comes to pain, I never get comfortable. But then just the other day, I just found that if I just get sometimes even just like an ice pack and just put it there, just hold it right there. Oh, that's the only relief I get. It only lasts 5 minutes, but that's the only relief I get. Okay, so that's your alleviating, and that's an alleviating factor. So the last one is severity. So severity is talking about how bad the pain is. So normally we give them a scale of 1 to 10, 10 being the worst pain they've ever had in their life. So make sure it's the worst pain they've ever had in their life that they're scoring it against, okay? Because you normally ask people this. So give me a number between 1 and 10 of where this pain features. 10 being the worst you've ever had in your life, and some people will say 11. And you just think, what does that mean? Okay? So make sure they get it in between the 1 and the 10. Then we move on to this now, which is past medical history. PMH, past medical history. For past medical history, the things you're trying to find out here is, have they had a problem like this before? Have they had any other problems before? Okay? Are they seeing any doctors at the hospital? If they're going to a hospital with their outpatients, and the name of the doctor, perhaps can give you an idea of the ward or department that they're being seen for. You can ask them questions like, have they ever been to hospital for any operations? Remember, people's ideas of operations are very different these days because we have a lot of minimally invasive procedures and lots of daycare cases where people come in the morning, they have their procedure in the middle of the day, and they go home in the evening. Okay, so for most people these days, they don't call that an operation. That's just, I just went to doctors and just got a little camera put in, and they just did that, and that was it. This is a keyhole surgery. Oh, lovely. That's not a real operation. A real operation, they get a knife and they cut all the way down here or something. So just be careful that people understand what an operation is. And you can even ask the question, have you ever been under anaesthetic gas before? Okay, so anaesthetic gas normally means big procedure, and that might help to trigger their memory. You can ask if the GP is investigating them for anything at home, because if the GP is investigating them for something, you need to know about that. That is quite important. The next thing you want to be talking about is a little catch-all, like a sweep to catch everything, okay, after you've asked them all these questions in their past medical history about any problems that they've had before. And what I normally do, because patients sometimes find it very difficult to be asked on the spot about their medical history, because it might span on 30-odd years. So I normally do this. I use this mnemonic, Jade, Tab, March. And basically what we've got is we divide it into 3 nice parts. These are your general things. These here are your respiratory things. And these here are your cardiovascular things. Now, I normally forewarn the patients, otherwise you could take ages on this bit. And remember, you don't need to do this particularly for your OSCEs, but it's really useful in future when you're practicing to be able to catch everything and not miss anything. So this is why I always hang on to this quite dearly. So I normally say to the patient, I warn them myself, I'm just going to ask you a couple of quick questions now, and these are going to be, obviously, these are going to be closed type questions, but you don't tell them that. You tell them, I'm just going to ask you a couple of questions now. I just want you to answer yes or no to these questions. So, J stands for jaundice. Jaundice. So it's, have you ever suffered from jaundice? Some people know what it is, some people don't. If they don't, or if you ever found somebody saying that you look a bit yellow, or being treated for being a bit yellow? And if that's a no, then that's great, then you move on. A is for anemia. Have you ever been quite pale or needed a blood transfusion, like a top-up of blood? And most people should know that. Then you move on to D. D is diabetes mellitus. Diabetes mellitus. So have you ever suffered from diabetes before? Okay, so this is a good question to ask. Or do you suffer from diabetes now? E is epilepsy. Have you ever suffered from epilepsy before, or do you suffer from epilepsy at the moment? And that covers all your generals. Then we move on to your respiratory conditions. So your respiratory conditions is, T is for TB. Have you ever suffered from TB before? Or do you suffer from TB? A, asthma. Have you ever suffered from asthma before, or do you suffer from asthma at the moment? B, bronchitis. Have you ever suffered from bronchitis before? M, we'll move on to cardiovascular now. M, have you ever had a myocardial infarction? You don't ask them that, do you? No, that's a real doctor's term. So try and minimize jargon. You ask them, have you ever had a heart attack? Okay, so keep using the patient's words at their level. A, angina. Have you ever suffered from angina? Do you suffer from angina? R, this is the rare one these days, this one. Okay, it's a rare one. Have you ever suffered from rheumatic fever? And then C, do you happen to know what your cholesterol is? Okay, and most people these days know about their cholesterol. They go to see the GPs, have it checked, and they come up to you and say, oh, I'm really, really pleased, it's less than 5, I really did it. It used to be 7 or something like that. And then we've got here, H is hypertension, so do you suffer from high blood pressure? And with all that, that normally covers a full sweep on your past medical history. So let's move on to the next bit. We're on to number 5 now. So number 5 is your DH, which is your drug history, okay? Drug history. So what medications are they on at the moment? And normally with elderly people, they'll have a prescription, repeat prescription, which they carry in their handbags and things like that. So which means they can normally at this moment in time can ask that, do you happen to have a repeat prescription on you? Or a list of your medication? And they'll normally bring that out and they'll give that to you, and you can copy the information down carefully, very carefully. And remember, this is how you should write down medication. You should write down drug name. In the next column, you then write down drug dose. And then you write here frequency of medication. So either it's BD twice a day, OD once a day, okay, or TDS 3 times a day. And then you write finally route, how it's going to be delivered into the person. So is it PO for per os by mouth? Is it IV? Is it IM? Now, remember, in drug history, this is the point where we ask whether there's any drugs they've taken over the counter at all, okay? So some people will take drugs over the counter at the chemist and not realize that this is actual medication. They'll just think, oh, you can get it over the chemist, it's not real medication, it's just a sort of a pick-me-up. You need to find out about those. Also, remember that other people use a lot of health foods and health food shops, and some of the herbal remedies that they sell are basically like drugs. Okay, remember, most drugs came from some sorts of herbs, so it's important to get those down, just in case it may have a bearing on the case, just in case. So that's your drug history. The next thing that we're going to move on to is we're going to move on to A, and A gets a separate bit on its own, which is allergies, okay? Now this is a very, very important one, an absolute must for your OSCE examination, because this is a patient safety point, okay? Patient safety scores highly in all medical school examinations. So allergies, do you have any allergies, okay? Are there any medications that you're allergic to? Especially get that one out, okay? And common allergies you'll find are to things like penicillin, okay, there's things like, some people have allergies to non-steroidal anti-inflammatory drugs. Example, ibuprofen. Now with all allergies, you can't just take what the patient says as, oh yeah, I've got an allergy to that. You then have to ask another question on top of that if they say they do have an allergy, and say, what exactly happened, or what happens when you take this thing that you're allergic to, and listen to what they say and make a note of it. Okay, so some people say, oh, I come out with red blotches, doctor, all over. I just look like a swollen bumblebee. And some people say, I just feel really sick, doctor, and I just can't keep anything down for days and days afterwards. And some people will say all other things, but you've got to make sure you make a note of that, because it may come to a stage whereby the drug that they're allergic to apparently, is actually the best drug to give them. And then somebody further up the chain, either consultant or somebody, may need to make that decision as to whether it's worth taking the risk to give them the drug which is the best for getting them better, when there's a risk that it may cause them to have an allergic reaction. Okay, very good. And then we move on to FH here now, which is your family history. Family history. Now, family history, in family history, we're trying to find out things like if there are any conditions in the family which we may need to know about, which may have a bearing on this case. So my opening question normally is, are there any conditions that you know run in your family which we may need to know about? And most people, if they have a condition in their family and they're aware of it, they will tell you. If not, a question you can sometimes ask is, if there's an elderly person, did your parents both live to a good age? And sometimes you can then find out if somebody died quite prematurely, quite early, what they died of, and that may indicate that there is something genetic within that family which may predispose this individual you're now seeing to a similar type of problem. So it's important to find that out. So family history. Also for genetics, this is where we start drawing family trees. Sorry, it's just where you have mum and dad and all the ones coming up underneath. So you can do your family tree there, but unlikely that you'll get something of that complexity. Then we go to social history. Now social history is rather loaded, there's a lot going on, okay? Because this marries up a little bit with what we found up here. Because what you've got to remember with history taker, this is a person who's come to see you. People have lives, just like you as a doctor has a life. After you finish work and you clock off, you're going to go home. And there's certain things that you do. Like you go to cinema, and you go out and you play sports, and you meet your mates in the pub, or whatever it is you do. There are things that you do outside, which define your social status, or what you do socially outside. So, social history, the things we want to find out from this are, does a person smoke? And if so, how many per day? You want to find out if they drink alcohol, and then also amount. And it's normally expressed in units, and per week is better, and then we can compare it against the national recommended guidelines. The next thing that you can do under social history is inquire about inquire about their job if you haven't already done so. So it's occupation again has a chance here. The other thing that has a chance here is to find out if they use any sort of, you've got to be careful about this, if they use any sort of recreational drugs. Okay? So these are medications which are used to help people with provide them with their kicks or whatever it is that they get from them. This is your wacky backy and all the rest of that stuff. So any sort of recreational drug use. You also want to find out, especially for elderly people, about their ADLs. ADLs are their activities of daily living. Activities of daily living. So, the activities of daily living are as follows. Can they dress themselves? Can they wash themselves? Can they feed themselves? Okay. Do they need any help to transfer from one place to another? So that's not from their house to the shop, say, or down to see their friend down south. It's transfer simply from a chair sitting to the bed, lying. Next, you want to find out about their mobility. So how many people does it take to move them around? Do they need one person either side, walking between two people, or do they walk with a stick? So how do they mobilize? Or was it with a Zimmer? So that's ADLs. Next, we're on to systemic inquiry. So systemic inquiry, we're talking about all the major body systems here. So the major body systems are CVS, which is cardiovascular, respiratory system. You're talking about your GI, which is gastrointestinal. We're talking about your GU, which is genitals and urinary system. We're going to talk about MSK, which is your musculoskeletal system. I'm talking about CNS, which is your nervous system. And don't forget, the largest organ in the whole body is your integument, which is your covering. That's what tegum means. Your covering, your skin. So we need to find out direct questions for all these to do a final swim to find out if there's anything else which may be going on. Okay, so for cardiovascular, the sort of questions I'm going to be asking for cardiovascular system are, do you suffer from have you had any chest pain recently? Or felt palpitations, your heart racing? Okay. What about shortness of breath? Or shortness of breath on exertion, when you're doing something, when you're exerting yourself. Syncope, which is these sudden blackouts, and that can be sometimes when the heart is not supplying enough blood up to the brain, so the brain goes on holiday. Hello, bye-bye. Okay, and then you hit the deck. And the other one is calf pain, when you're walking and you feel pain in your calves. Oh! And you stop, you wait a little while, and the pain subsides. Oh, bliss. Then you're ready to walk again. Ah! All ties up, and that's to do with the blood getting down to supply these big bulky leg muscles. Okay, and if you've got some blockage in your arteries because of all that fatty animal fats which are lining the arteries and they're stopping the blood getting to those big juicy bulky muscles, then those muscles are going to start screaming in pain, yeah, give us some oxygen and glucose, and that scream is felt as that sharp pain. Good, so that's a cardiovascular problem. The other thing is obviously chest pain itself. So if you've got chest pain, it's very, very, very important to find out. So do you have any pains in your chest at all? The last one, moving on now, is respiratory. So respiratory systemic inquiry involves asking questions like, do you suffer from a shortness of breath? on exertion, or have you had any shortness of breath recently? What about a wheeze? Have you had a wheeze recently? That's that. Stridor, okay, so that's an inspiratory noise, stridor, so that's an upper airway problem. Hemoptysis, heme for blood, so hemoptysis, are you coughing up blood? Sputum, so producing any sputum when you cough? Are you coughing in general? So that's respiratory. GI, which is gastrointestinal, you're asking questions like, any vomiting, any diarrhea? Okay, have you been losing weight at all? Or have you experienced any loss in appetite? So these are all those front-loading things. Have you been vomiting blood? That's hematemesis. You've been vomiting blood. And then you want to start asking things about the other end of the GI system. So, have you had any blood which you've been passing? Or slime or mucus from your rectum? Any change in your bowel habits? You used to go once a day, now you're going all the time, nearly every 25 minutes. Yeah? Bloating of your tummy, pain in your tummy, or any tenesmus, really straining to pass feces. Next, we move on to genitourinary. So genitourinary, you're asking questions like, do you have any blood in your urine? So hematuria. Any dysuria, pain when you're passing urine. Any nocturia, passing urine at night, getting up to go to the loo at night. Frequency, are you having to go more frequently than you normally do? Urgency, are you feeling the burn? I need to get to the loo quite quickly. Dribbling, so are you just dribbling urine all the time, so incontinent? Hesitancy, so you're hesitating before you actually go, and that could be a sign of benign prostatic hyperplasia. The next one is incomplete voiding. Okay, so you've got urine which remains within the bladder, and you don't pass it all in one foul swoop. Next we go on to MSK, which is musculoskeletal. So you're asking about morning stiffness. Do you have stiffness in the morning, or is your stiffness worse at night? And the pain, do you have pain worse in the morning, or is the pain worse in the evening? And that can differentiate between two types of arthritic conditions. One is rheumatoid, and the other one is osteoarthritic. Then we move on to CNS. For CNS, we're talking about things like, have you had any fits recently, any faints, any weaknesses, any headaches, any loss of sensation, so people have had a stroke, any confusion, any slurring of speech, or anyone said your speech has been a bit slurred without having any alcohol, by the way. And then the last section is skin. Remember, skin, that biggest organ in your body. Any rashes, any ulcers, any lumps or bumps that you've noticed recently. So that's number 9. And then we finish here on number 10. And number 10, ice, ice, baby. Dun, 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 ice, ice, baby. Now ice, what's it all about? Well, there's several parts to ice, and you've got to be clever. Anybody can ask ice. I can teach a 5-year-old to ask about ice, but a true medic will be very clever on how they ask ice. I stands for ideas, concerns, and expectations. Okay? So the ideas is what is the patient's idea of what's wrong with them. Concerns is what concerns they may have, and E is expectations. What do they expect to be done for them? Now you can't go up to the patients and just ask, so what do you think it is then? Okay? Because they'll turn around and say, well, you're the doctor, you tell me. Okay? So that's no good. You can't go up to them and say, so, do you have any concerns? And they'll say, well, of course I've got concerns. I come here to see you, haven't I? So you've got to be careful about that. Expectations. So do you have any expectations? Yeah, I've got expectations. I want you to treat me. How about that? Can you do that? You're a doctor, aren't you? Yeah? So you've got to be careful how you ask this. So what I normally do, this is my top tip to students, always hit the empathy notes. And remember, there's marks in the exam for empathy, and really mean it, by the way. Don't just do it to play up, okay? So start off with empathy for each one of these, and you'll just find you're just cruising to it nice and gently. So let's start with ideas. So then you say, you've just spent all this time collecting these masses of information on the patient. So you've now exposed them for who they really are, okay? So you know all about them. So now what you do is you use all that information as a weapon against them. So you then turn it round on them and you just say, you know, I can see that you're obviously doing this for your job. It must be quite busy, and you've had this cough. Now you tell me it's going on for this long, and it's causing you all these problems. And if it's been affecting your sleep, it might have been affecting your sleep and things like that. And I see you've had these problems in the past. Have you had any sort of thought as to what you might think it might be? Yeah. So this is where you turn it round on the patient now, and because you become in with that empathetic side of things, hopefully you should lead them to a stage where they're just like in the zone to now share with you what their idea is. And they'll say, yeah, doctor, you know what? It's interesting, I've just been thinking about this for the last couple of days, and I think I may have a brain tumour. This headache just won't go away. I think I may have a brain tumour. And I'm really, really worried because I've got small kids at home. And normally you find they move straight from the I into the C. So I'm really concerned. I've got kids at home. If I have a brain tumour, this is really bad. I was really worried about this. Okay? So you normally find that. If they don't, you can always ask them after they say, so you, I think, doctor, it's because I've got a brain tumour or something like that. Then you then go on to the next question, which is, so I guess you must be quite worried about that. Okay, so you're hitting again that empathetic angle. And then hopefully they're going to come in and say, yes, well, yeah, I am, doctor, I'm quite worried about that. It's really, really concerning me that I've not been able to sleep. I mean, I've not been performing well at work. My work's affected. Yes, and my boss has been asking me what's been wrong with you, and I just didn't want to share. I didn't want to burden him with all these problems that I've got. Okay. Then you can move again into E. Start off with empathy. Okay, so this I'm going to write in red here so you guys don't forget. Empathy. Because for E, expectations, for E, what we do here, we start with the empathy, which is, well, I can see that you're quite concerned, and I can see the idea that you shared with me that of what you think it may be. What would be the best outcome today for you for coming to see me on this visit? What would be the best outcome? Now you're just giving them the forum, putting them on the podium, and they are going to tell you exactly what it is they wanted from you. They're on the podium now. So expectations. Rather than them asking them, so what do you want me to do for you? Yeah, and what? So very, very, very different. This is very clever, this bit. So you've got to be really clever about how you do this. And then somewhere in this section here, you want to be thinking, just before you present back your history, you want to be thinking about possible risk factors for this particular condition why this patient came in. Okay, so you want to be thinking about some risk factors after you've collected all your information for why it is that this patient came in. And that, ladies and gentlemen, if you can do that, should get you hopefully some OSCE success in the history taking. So I'm just going to go through and just do a quick recap of those 10 key points. Number 1, patient profile. Number 2, presenting complaint. In number 3, the history of the presenting complaint. This is the gossip note. In number 4, past medical history. In number 5, the drug history. In number 6, don't you forget those allergies. In number 7, family history. In number 8, keeping it social. In number 9, systemic inquiry. And number 10, ice, baby. Dun, 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 dun. Ice, baby. Dun, 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 dun. Now stop. Collaborate and listen. Ice is back with a brand new edition. Something.